Well, I'm going to go ahead and start off the meeting, and I'll just keep letting people enter as they show up. But again, welcome to the PNP Pals Hope Zoom weekly call. We're so excited to have you. We're glad to be here to do what we've been doing since 1998, offering hope, support, and encouragement for everybody who's fighting PMP and other cancers of the abdomen. We are super excited today to have special guest Professor David Morris from the University of New South Wales in Sydney, Australia, to talk to us about the BromAc trial. And obviously there's been lots of talk about this trial and lots of excitement. And I think that's partially why we have so many people here today. But as we start that discussion, Professor Morris, I wanted to ask you for your recollections about our founder, Gabriella Graham, who each of us is on the board of PNP Pals. We're here today because of her work and helping make sure that we got to care. But we know that you had interactions with her. So maybe we start by you sharing some of your memories of Gabriella.
Well, my memories of Gabriella are certainly very fond. And I think that it's a great example of how you can use your energy and enthusiasm and ability to help other people. And she did that, and PNP Pals is because of her. And I think it's a great thing that we have this organization for this disease. And yeah, I remember Gabriella well.
Yeah. She was a unique individual. She had quite a bit of spit and fire inside of her. So she's a memorable person for sure. So taught us how to do what we do. So we're grateful for her teachings and her memory for sure. Well, that's great. Well, we're all interested to hear about the BromAc trial. So what can you tell us about it? Tell us about which patients are eligible and how this is going so far. We'd love to hear about this.
Thanks. So let me start by explaining what BromAc is and what it does. BromAc is a combination of two agents. One is bromelain, which is from the stem of the pineapple plant. The other is N-acetylcysteine. Both agents are already used in medicine for other applications. But what we found some years ago, which was really quite original, was that when you put the two together, it actually dissolved tumor-produced mucin. And that's what we were looking for, and we looked at a lot of other compounds before we did this. And so we can fluidize mucin within a short time. And we have then used that in patients with pseudomyxoma and other mucinous tumors to dissolve the mucin and to be able to remove it from the body. At the moment, the study, which will start in the US shortly, will be in patients with inoperable pseudomyxoma. And the contraindications to the use of BromAc are allergy to either agent, that is pineapple, or to N-acetylcysteine. We don't like people to have coagulation difficulties. That's probably a theoretical risk, but we are excluding people who have uncorrectable coagulation defect. That's pretty much it.
Excellent. And so, one question that comes to mind is, how long has the trial been running? I understand in Australia, it's been running for some time now.
Yeah, actually, thinking about it, it's been going for about 2 years, and we've certainly got follow-up of that order in our first patients. And we've now treated 34 patients, and we published a while ago the first 20, and we described 80-odd% response rate in those patients. We've also recently looked at the long-term outcomes in patients. I guess that knowing which patients respond best and how often to use it are things that we're still learning.
Certainly. Yeah. Well, this is great. And just as a reminder to the group, again, thank you for registering for the event. It's very helpful for us to stay connected with you. And many times from the Hope Zoom call, we've been able to connect individuals and physicians, and that's been one of the most rewarding parts of this. So thank you for registering. We do, Professor Morse, have a list of questions that people have sent in as well.
Sure.
And team, due to the large size of the group, we have muted the lines. But if you have additional questions that you aren't hearing asked now, feel free to send an email to zoom@pmppals.net, and we will go ahead and collect those and make sure all the questions are being asked. But so Professor Morris, again, the most popular question was, when will this trial be available in the US?
Okay. I've been very frustrated and disappointed that we haven't been able to get it going already, but we are now very close. We have manufactured sufficient quantity of the drug to make it available. We have 3 trial centers at the moment in the US. We submitted what's called an IND to the FDA, and the timing of that should allow us to start very soon, certainly within the next couple of months. I don't foresee any other delays, but I've been disappointed.
Sure. Well, I work in FDA registration myself, and I know that can be a time-consuming and frustrating and laborious process. So we certainly empathize with your situation. But so this trial also is a trial that has been funded and supported by the ACPMP-RF, and so we're glad for their support and partnership in this. And I know they have resources available that could help if that's something that would be beneficial. So we'd be happy to help make those connections too, if that would be helpful. So another question that came up was, is this intraperitoneal attack being used on lamin?
So at the moment, we're using it in all mucinous tumors, including high-grade tumors. I'd have to say that the lamin results are the most dramatic, where we have seen rapid and easy resolution of the highly mucinous deposits. We also know from our laboratory and animal research that when we use BromAc with a drug called gemcitabine, we see a considerable increase in efficacy of gemcitabine. And so for the higher grade tumors, we will be pursuing that as a treatment option. I hope that will start in Sydney in the next months. The NIH have also expressed a real interest in pursuing that trial in the US. So probably they will start concurrently. We certainly have great animal data for high-grade colon cancer, gastric cancer.
That's fantastic. It's exciting to hear about these advances and what you're seeing with the data and the practical successes. So this is really good. I know as an engineer who has to deal with moving fluids, you know, mucin can be tough, and we hear our specialists talk about this challenge all the time. It's not something easy to get out. So the ability to liquidate something like that and move it that's great. It's good news. So one question, one of the inclusion criteria is that a patient is high risk for repeat surgery. Can you elaborate on what that would mean?
Yeah. So I'm a surgeon, and I deal with patients with peritoneal cancer almost every day of the week. And I think that that's one of the important things for patients with this disease, and that is that you should be treated by experienced center. You have some great experienced centers in the US, and we're going to work with initially 3 of those for this trial. Why I'm saying all of that is that who's inoperable depends a great deal on the team that are looking after you. And at present, we are only advocating this for inoperable patients. So patients who are unfit for surgery because they have serious comorbidities or because their tumor is actually physically unremovable are at the moment the patients we seek for this trial. I also need to point out, though, that I think that it's quite likely that this treatment will be used in patients with much earlier disease as a non-invasive, easier, safer option than current operation. And I think that laparoscopic removal of tumor together with our dissolution is going to be something that is going to be interesting.
Absolutely. No, that's and I would say for the benefit of the group, advances in science, this is how things work, right? We have to prove safety and efficacy first and understand the pharmacodynamics, or how the body processes the drugs that are being administered. But once those methodologies and those drugs are approved and understood to be safe, then our physicians have the flexibility to use them at any time during the course of disease treatment and recovery. So, and tell me if I've got that right, Professor Morris, but I think this gives us just one more arrow in the quiver, so to speak, that we can use advantageously for fighting the disease.
I very much hope so.
Yeah, it's great. Another question. So I see that there's two different administration methods. One is a direct injection into tumors, as well as a general perfusion intraperitoneally. Is it difficult for that direct injection? Are you finding that to be harder? And what benefits or pros and cons versus those two methods?
It's really patients, in that some patients have localized pockets of recurrent tumor. And in those patients, a percutaneous approach under a scanner by placing a small pigtail drain into the collection together with administration of the drug is the appropriate way of doing it. If you've got generalized peritoneal disease, then we've given it directly into the peritoneum. So yes, there are two different ways of using it.
Good. And so we did have a question come in, and I think this discussion just coincidentally answers that question. Yes, these drugs are being injected and administered carefully into the abdominal cavity. This is not an intravenous treatment, so to speak. It's not going into the veins. It's going directly into the abdomen or injected directly into the tumor itself, which is even a more direct approach. Good. Well, there's a question here which PNP pals will render an opinion on, and Professor Morris, I absolutely welcome your either support or modification of that. But when should someone ask for a second opinion? Our experience shows us that patients who are educated and get multiple opinions tend to do better during treatment and recovery. And Personally, I'm a 16-year survivor of appendix cancer, and every time I go to a conference with the specialists or I see one of the specialists on my own, I learn something new. And so, and I think Professor Morris, I think you would say you always encourage patients to get other opinions as well. But I welcome your—
Look, I really think that this is probably one of the most important aspects of patients' care with PNP, and that is you must have the opinion of an experienced center. And of the patients with PNP that I see from America, many of them have been treated by local surgeons with little knowledge or experience of treating this disease. And as I've said, you've got great centers in the US for looking after this disease. I would always have a second opinion.
I mean, in America in particular, we have access to some of the greatest advances in healthcare technology, but it's vital that you ask for it. When you go see a particular specialist, if they're your local hospital, that is the physician's job to tell you, yeah, I can help and this is what I can do. But it's not necessarily true that they have to tell you all of the possible ways that the disease can be treated, especially if they're not familiar with it. So it's important that you seek out care. Far too often, every week, we talk to patients who have been treated by local surgeons, Professor Morris, and they've had an hour or two of surgery. And we know that this is an extensive disease that requires detailed experience, and a 2-hour surgery would be very, very short for our disease.
I've done 1,500 peritonectomies, and our average peritonectomy would still take 9 hours, and some will take 16.
Yeah.
But and the first operation is probably the most important operation.
Indeed. I mean, we've been super pleased to have other HIPEC specialists on these Zoom calls, and patients who have felt really confident that their local surgeons had given, good advice. And it was good advice. But again, we always recommend, if you can, get to a specialist, and we know that the studies show that, physicians and centers, right, they should have done 130 to 140 cases to get past the learning curve. So, so it's great to see those connections being made, and getting people to care, really.
Yeah.
For sure.
Chris, could I add something to that?
Of course, Charmaine.
Well, I just wanted to say from my experience, I had my cytoreduction surgery in HIPEC 11 years ago, and I had PMP for 9 years before that. But even beyond just seeking a second opinion from your local surgeon, I would say that if you speak to a specialist and the specialist says you're not a candidate for surgery, I would highly recommend seeking a second opinion, because I started moving from a local doctor in Austin, Texas to a specialist. The first specialist I consulted said I was too far gone. He wouldn't touch me for surgery. He thought I would have a terrible quality of life if I did have surgery. And I sought another opinion, and I had my surgery in HIPEC, and 11 years later, I have no evidence of disease. The surgery was difficult, but no more difficult for me than I think for most patients, really. And, I went to one of the best HIPEC specialists. It was Dr. Sugarbaker. And in addition to knowing so much about the disease, he's also a fantastic surgeon, and got through the surgery. It was hard. I had some adhesions, et cetera, from my previous surgeries. But I just want to stress that even other specialists may say, I really can't do anything to help you. I feel like your case is too complicated. The surgery will be too hard on you, whatever. And another surgeon may look at it differently. And that was certainly the case for me.
Yeah.
That's great. We're all very glad to have Charmaine here. She's on the board of directors at PNP Pals. So sometimes the most impactful thing we say is our survival time. And Charmaine, how many years is it for you total?
22 total since I was diagnosed.
I never get tired of hearing that number.
I love saying it.
That's great. That's fantastic. So let's see, I have more questions coming in. So this is a good question. This is a detailed question here, Professor Morris. Does the patient population for which these drugs are being tested include those with mucin bound in scar tissue with disease that's embedded in the liver or diaphragm, right? So now we're getting to a little bit more technical details here.
The answer is it all depends. And if there is on the scan, a pocket of tumor which is place a brain into, then yes, they are. And that may mean that multiple needle placements may be required, but that's eminently possible.
And one question I have, I know with a lot of the immuno drugs that we have now, right, there's a lot of HAMA responses or immune responses. Are you seeing those types of that response from the human body in response to these drugs, or are the side effects lower?
Well, the side effect profile of BromAc to date has been very good. We do get an inflammatory response. CRP, C-reactive protein, is raised for the first couple of days after administration, but it doesn't make people sick. Most of these treatments are actually done as an outpatient. So it's had a good profile so far.
That's
But
great.
it's a work in progress, and whilst we've treated 34 patients, that's still early days in the life of a drug. But yeah, it looks good.
That's great. I took Erbitux, and so that was quite a wicked response. I had the full upper torso response. So that's great to hear that the side effects aren't too terrible. They're manageable. Good. I think that is all the questions that I'm seeing in here now. And so, what's that?
Back to the sheep.
Back to the sheep.
I'm on my farm. I'm having the weekend off, and going back to the sheep.
So back to the sheep. Yep. I was going to ask what was on the agenda at the farm today.
Thank you so much.
Well, and I did want to take a moment and remind folks, PNP PALS has been here offering support again since 1998. And we have a number of programs that, I personally took advantage of, and I would encourage you to take advantage of as well. Our most popular program is our Get Well Cards program. And this is just a couple of the cards that I personally received. I've got a whole box that I keep very close to me and I see every day. Also, the Bare Bottom Bear program, where you can get a bear made for you. My surgery was on Flag Day in the U.S., and so you can see that, that's when I received mine. And as you're starting your journey, we're happy to provide the starter kit for you, right? So there's different things you're going to need, including hand sanitizer, a good notebook to take notes with your physician, and some other things as well. So send us an email at info@pnppals.net, and we're happy to send those things to you and send cards your way for your particular situation. James, I see you looking to say something.
Yeah, there's some more questions.
Yes, just people are raising their hands. Chris, do you want to ask questions?
Let's see. I have to page through and see everybody. So I got another question coming in here at Zoom. Good question. Good question. Can the BromAc be used on lung mets?
Yeah, good question. We have one American patient, a young man who had pleural disease from pseudomyxoma, because pseudomyxoma does tend to spread through the diaphragm and involve the chest. He had a good response. We've also treated one guy in the chest who had hard tumor, and that wasn't anything like as effect. So the answer is, again, yes, but it depends.
Now, this is pleural cavity or lung
This
met?
is pleural cavity. Lung met, no.
Yep.
Not at the moment.
Not at the moment.
Yeah.
So I'll just remind the group, if you can email the questions into Zoom. Oh, here they come. Here they are. Perfect. Let's see. Does BromAc reduce adhesion risk? Good question.
Well, I haven't worked on that, but there is a good paper showing that it can do, yes. And the important sort of use of BromAc at the time of surgery to increase the effect of HIPEC or EPIC is something which we will work on. And knowing that it reduces adhesions is a good thing. On the other hand, that makes me concerned that it may affect anastomotic healing. And before we use it in that setting, we need to show in animals that using it in the presence of bowel anastomoses doesn't affect those anastomoses. So it's a work in progress. It is happening. I'll know soon.
That's great. Very good. So let's talk about the situation in Europe. And so part of the question is, can the BromAc be used during debulking? And I think the answer to that question is not yet, but I'll let you respond to that.
Okay, well, it's a very attractive idea in that in parts of the cytoreduction where you simply can't remove the disease, for example, sometimes we get beaten by the surface of the small bowel and that we just can't get it all off. Treating that area with BromAc during an operation is clearly attractive. Will we do that? Yes. Have we done it? Well, we've done a bit. We've certainly treated one patient in that way. We've certainly in the laboratory looked at solving pseudomyxoma off bowel, and yes, it can be used there. But again, before we're able to advocate its use, we need more safety and efficacy evidence. But yeah, it's a good question, and we've thought about it.
It's good. And Professor Morse, I will humbly ask your opinion on this. Do you think we as patients, is it okay for us to ask for our surgical oncologists, our HIPEC specialists, to perhaps consider trying some of these things on a case-by-case basis? I don't know what your thoughts are there.
You know, I think that the peritonectomy community in the world is a very interactive one. And certainly when we've been talking about BromAc, there's been a lot of interest. And so I don't think there's going to be much of a problem in sort of disseminating the knowledge and the use of it when it's appropriate.
Yep. And so are there any countries where these drugs are approved for use, or it's still under clinical trial everywhere?
It's under clinical trial. Both agents are approved for other uses. BromAc is used for burns, for debriding third-degree burns, and N-acetylcysteine is widely used as an antidote to paracetamol overdose. So both of them are registered drugs. It's just that they haven't been used together until, and they certainly haven't been used for this disease.
Very good. Okay, good to know. How about non-mucinous appendix tumors? Invasive adenocarcinoma, would this be appropriate for that?
Yes. So what we've found was that when we grow adenocarcinomas in the laboratory, the sensitivity of those cells to chemotherapy is profoundly improved by bromelain. And that's because all adenocarcinomas do have a degree of mucin in their cell wall or intracellular. And when you dissolve that mucin, your ability to then destroy those cells with gemcitabine is improved. So we're certainly working on that. We hope to have a clinical trial addressing that in Sydney.
Brilliant. Okay, very well. So how about oral bromelain? So we have supplements. What are your thoughts there?
Yep. I think it's very difficult to get enough bromelain into the area where the problem is by oral administration. And I don't think it can be done, to be frank. We also are interested in whether we're able to administer venous bromelain or BromAc. And at the moment, I can't say that we are able to do that. I think there will be some safety issues around that, but we're working on those in that we do have ways of making the bromelain more available to tumors after venous administration so that you don't get systemic side effects. So oral, I can't see it at the moment. I don't think that's likely.
Very good. So the question here, so when should we begin inquiring with our oncologist? I'm not sure which country this is from, but so, I mean, perhaps it's not too early to start discussions, but again, I think it's going to be a case-by-case basis, and obviously limited by when each country, approves the use, permits the trial to begin.
Yep. So Eindhoven in the Netherlands and Lyon in France are going to be two European centers, which hopefully will open at a similar time to the American ones.
Good. So UK and Europe, there's a couple questions there. So Eindhoven and Lyon, are those the only two centers in Europe?
At present, yes.
Are you seeing interest from the specialists in other centers there as well?
Yes, but I'm an academic surgeon, and we formed a small biotech company around this drug in order to be able to develop it. And we have limited resources to kind of open lots of centers at the same time. Although we're giving the drug free for the trials, we still do have costs of compliance. So we can only do a certain number of places at one time.
Sure. Yep. And how about the number of patients in the trial, right? Is that number expandable, or is 100?
Yeah, so we've been told by the FDA that they'd like 100 patients in the trial, but it's also possible for people to be treated off-label. And so once the IND is in place and trials are in place, it is possible for patients to basis.
Good. Okay, very good. Ooh, that's a good question. Is BromAc available under compassionate use for patients who have exhausted all options in the United States? I'm not, I don't know. I'm not.
Yeah, I think that means I go to jail, right?
I don't think you can answer that question.
It's pretty much like that, in that I can't actually supply. I have this week agreed to supply drug to a physician in Taiwan because he has exhausted all other options and will be treated in a center on a named patient basis, and they are dealing with the legalities in that country. But in the US, until we have the IND in place, we cannot do that. But I don't think that's a problem, in that the IND really, it's a matter of a week or so. And so I don't think that there is really any time problem with supply, at least in the US.
Very well. So that is all the questions that I see so far. If there's a couple more, I'll wait till we send them in. But I'll take a moment and pause while we're looking for those last questions to again reinforce. I've been going to the conferences personally, as well as the rest of the PALS team, for over 15 years now, and we're very lucky to have geniuses of this degree who are working on our disease. Truly, some of the most intelligent men and women that I've ever known in my life. So very grateful for that. And it's innovations and science like this and navigating these very difficult regulatory processes to get these advances to us. So we're very grateful. And I can see why there's a lot of excitement about.
Hey, that's a load of crap. I've just got a good team.
Well, you're on the farm. You know how to deal with crap, so that's good. Well, this has been incredibly informative. We're about 40 minutes past the hour now. Adele or Michael?
I think there's another question or two.
Okay. Still others coming in. I think, well, we hit the refresh button one more time. Is it a one-time procedure? I'll let you talk to
No.
that, Professor Morse.
No, it's not a one-time procedure. Usually in a patient with high volume disease, we would do a few treatments at the initial treatment, deal with the areas that are the most problem, and then deal with other lesions over months, but all as an outpatient. And in terms of retreatment, yes, retreatment is possible, and we have experience of that.
This is really fantastic, really, really interesting. Well, you know, the whole point of these calls and what we do at PNP Pals is to give patients hope. And, you know, again, we find that educated patients are patients that tend to do better and have more success. So we're very grateful for the innovations in bringing the science to us. And thank you for your time. Another question comes in. Who are the lead investigators at Eindhoven and Lyon?
Okay, so I'm absolutely dreadful at names. So I'm about to fail. It's Ignace de Hingy in Eindhoven, and in Lyon, it's dreadful. I can't remember his name. He is my friend, and in fact, one of his surgeons is with us at present in Sydney. If anybody wants names, just email me and we'll send them. Yeah, I'm sorry, it's gone.
That's okay. Hold on. I see. No, it doesn't list the name at the sites. And so, folks, I am looking at clinicaltrials.gov right now, and you can enter the disease of pseudomyxoma peritonei and the other term of bromelain, and then you'll find the trial here. And it does list the sites, but not the principal investigators at each site. So our apologies for that. Professor Morse's email is also listed here at clinicaltrials.gov, and it's david.morris@unsw.edu.au.
And it's Olivier Glihen. My memory kicked in.
That's great. Well, folks, usually we have the opportunity to have higher touch and engagement with one another. This has been a particularly well-attended event with lots of folks, and so today is a slightly different format. Next week, we're going to be celebrating Cancer Survivors Day, and we'll be back to our regular high-touch environment, so we'll be looking forward to that. We can all support one another. But Professor Morse, thank you so much for sharing this information with us today. We really appreciate it.
Thank you.
We may have one more question.
One more question.
At the last minute, but I echo the comments from a patient perspective. This just gives us great hope. The advances that are continually being made, and the opportunities that we have as patients today as compared to years ago.
So Roz is asking, can you be in this trial if you don't have mucinous tumors? I think the answer, Professor Morse, is no.
No.
No, they must be mucinous tumors. Okay. Well, good. All right, then with that, I will. Any more questions coming in? No. Well, good. Well, thank you so much again, everyone, for taking the time on the weekend to be here, and especially Professor Morse. Thanks again, and make it a great day, everybody. And if you have questions, you can email them to zoom@pnppals.net, and we'll be happy to follow up in any way we can. Thanks so much, and take care.
Bye.
Bye. Thank you.